I'm a clinician mostly, and I have maybe a naive question. From time to time I have a patient, for example, with Pheo and with very high blood pressure, and he's on multi-drug therapy. And then I'm asking myself, should I stop which drugs before doing the urinary collections, and I feel very insecure about doing this.
Yeah. I don't really think it's necessary to stop.
Usually I'm not stopping, but I feel unsure about doing this.
I don't think it's necessary to stop any drugs in the first testing.
I'm not sure that he has a Pheo. Before that, a patient coming with, an adrenal mass and high blood pressure and maybe a clinical suspicion of a Pheo.
Right, but I don't think it's necessary to stop There are some drugs, of course, some antihypertensives, but if you get a positive result and you're concerned, then you can maybe take the patient off the drug. But beta blockers, all these alpha blockers, almost all the antihypertensives have no, at least on modern day tests. And if we're doing with LC tandem mass spec, there are no interferences at all, really. Phenoxybenzamine can be a concern because you can get elevated test results with phenoxybenzamine, but I wouldn't necessarily take a patient off phenoxybenzamine if there's a high suspicion of Pheo. I would do the testing, and if it's really, really elevated, it's a Pheo, and if it's just slightly elevated, then you have to be concerned and maybe taper and replace with doxazosin or something like that.
It's very difficult to have a patient, a hypertensive patient, which has not been already diagnosed with pheochromocytoma on phenoxybenzamine. I mean, you don't use phenoxybenzamine as an antihypertensive drug normally. You use other.
I know, but from experience, for instance, at the NIH, we were a referral centre. We were often referred patients who were put on phenoxybenzamine immediately when there was a suspicion of Pheo. They were referred to us, and it turned out that they did not have pheochromocytoma.
This should not be
done.
done.
This is the situation.
Yeah. Much better to use doxazosin in this case. Yeah, of course.
Graeme, we talked about this the other day a little bit, but I think it's very important when you're looking for a Pheo to do a plasma metanephrine, as you've always said, plus the plasma catecholamines, which includes dopamine. An elevation of dopamine is certainly much more significant, I think, than urine. And collecting urine is always uncertain whether you've got the complete collection, and if you're doing a child, certainly it's difficult to collect. So I think sort of as a confirmatory, you've got not only metanephrines, plasma metanephrines, but also plasma catecholamines. I think that's a much better way of starting off. Anyway, I'd love to have your comments. I think you and I sort of agreed on that, but...
Well, as I said before, I think a minimalist approach to initial diagnosis is best, otherwise you're going to have problems tend to experience problems with more false positives and the need for follow-up. And for a patient who's symptomatic and hypertensive, the typical patient, if the norepinephrine and metanephrine plasma is normal, then you can just discount the pheochromocytoma. This isn't a symptomatic patient. The trouble is that not all tests are equal and not all laboratories are equal. So you have immunoassays for metanephrines, and then some laboratories are using ridiculous upper reference intervals that haven't been, that are out of the package insert or what have you. So these are other issues with the initial diagnostic testing. But certainly once you have a positive test result, then I do think you can throw, all the biochemical tests to some extent at the patient, but I wouldn't include catecholamines initially.
In the follow-up of patients that secrete norepinephrine, the epinephrine or norepinephrine, when you're following these up in post-treatment, do you need to do both metanephrines and norepinephrine? You know, we get norepinephrine metanephrines, norepinephrine.
No,
epinephrine.
yes, I know. But I don't think that's necessary in the follow-up either for most people. I mean, first of all, I think you also have to consider the initial presentation of the tumour and what kind of tumour it was. And if the tumour was a typical pheochromocytoma that produced norepinephrine and metanephrine, you know, so fine. And then you should be, you know, concentrating on those. I mean, you could get some tumours that are like an SDHB patients that don't show these patterns, and then you have to worry about methoxytyramine and chromogranin A too. But, you know, this is where an individualised approach is important. I think I mentioned this before. Does that answer your question?
But do you need?
No, you don't need
the
catecholamines.
epinephrines. If you do, can you just do
All you need is
the
norepinephrine and
metanephrines.
metanephrine. All you need to do is measure. In my experience, norepinephrine and metanephrine, I mean, you could throw in, but no labs have it, you could throw in the follow-up methoxytyramine because of the possibility of malignancy coming on. But at the moment, no laboratories have that, and I would hope that that will be available in the future, but I wouldn't want to have it available on a wide, that everyone provides that test ad nauseum, and you end up with a lot of problems with false positives.
You get the dopamine, you've got dopamine, so you look easy.
Certainly, you're right. At the moment, one could measure plasma catecholamines in follow-up. This is, I think Bill raises a valid point here. Without the methoxytyramine, so it's not a bad idea to measure plasma catecholamines with the norepinephrine, epinephrine, and then dopamine. Of course, the dopamine has to be measured out. It's very, very difficult to measure dopamine in plasma accurately. Not many laboratories can do this. Dopamine typically is below 20 picograms per mil. And generally there are little peaks by, you know, so, and there are no LC tandem mass spec methods yet for plasma catecholamines, and you certainly cannot do urine catecholamines. This is a waste of time. But so this is a problem with even the plasma catecholamines.
Last question?
I suppose this is in a similar theme to my previous question, but one thing that's hard for the patient sometimes to get a handle on is what the proportions of pheochromocytoma in their pure adrenal gland form versus the extra-adrenal. What are the numbers? If you have 100 patients, what proportion do you think are going to turn out to be paraganglioma versus traditional and classical pheochromocytoma?
I did a recent survey on the literature on this and compiled all the results, and it's published now, just coming out. I can't recall offhand, but I think someone's presentation here indicated higher, like 18 or 19% or something. I think, from what I could determine, it's closer to 14 or 15, 16% extra adrenal. But this excludes, you know, this is the typical extra-adrenal sympathetic paragangliomas. I'm not talking about the head and necks.
So it doesn't really include Ds, for instance, SDHDs?
You know,
Roughly.
this is the problem. I think when you know this categorization of tumours, and another issue is also these paragangliomas. I think the head and necks are probably less likely to be malignant. Is that correct? Does everyone agree with that? That they're less likely to be malignant? And for instance, I noticed in some presentation that there was a suggestion that SDHD mutations are associated with a low risk of malignancy. I don't think that's correct. I think that's because we're counting the head and neck paragangliomas, and I think if you looked at the actual abdominal, thoracic paragangliomas, we're going to see about 30%, but just the typical extra-adrenal 37% rate of malignancy.
But the traditional numbers, if you, as a patient, we do internet searches and things like that. The traditional numbers we're told is 90-10, 90% Pheo, 10% PGLs.
It's roughly right, you know, but
it's
we're getting a little closer. It's looks like it's more like 14 to 86%.
And maybe a little
and
higher.
you know, the rule of 10 isn't that far out for the adrenal malignant. You know, I think it's about 11%, 9 to 11%. Now, this is pretty close to the original 10% rule, at least for the adrenal pheochromocytoma and malignancy.
And one last question, if I could just ask. The similarity is the chromaffin tissue between paragangliomas and pheochromocytomas. That's where the grouping comes together. But is there any other characteristics, apart from being extra-adrenal, that paraganglioma demonstrate?
I think that's a good question for Art Tischler to answer.
Well, there is one major difference, which is that the extra-adrenal sympathetic paraganglia are almost always noradrenergic. So there was a comment made yesterday about how environmental cues determine the ultimate phenotype, but that's really not entirely true, because there is some degree of programming that has occurred before the sympathetic precursors reach the adrenal medulla or the extra-adrenal sites. And I think those differences may be explained by by different developmental windows in which the genes that cause Pheos nor paragangliomas are normally active.
Thank you, Dr. Tischler. Thank you. Thank you. Thank you, Dr. Eisenhofer.